Good morning, everyone. I think we've all been getting some very interesting, messages from today's lectures. So we started with introduction and real-world evidence and health economic assessments. Then we moved on to how these apply to the selection of gonadotropins. And my role over the next 10 to 15 minutes would be just to present some of the evidence around the health economic assessment of gonadotropins. So I would like to start, of course, by thanking the organizers and Merck for the kind invitation to be here. This is my disclosures, and I would like to focus on the fact that I've been fortunate to receive support from multiple pharmaceutical companies selling and profiting from some of the products I will be discussing about today, and that some of the evidence that I will be presenting today have also been funded by Merck, and this is clearly noted in the relevant slides. So we already had a first description of why health technology assessment is so vital into decision making in any field of medicine. And by obviously health technology assessment, we all have the 4 pillars that we assess, which is obviously efficacy, how effective an intervention is, safety, how safe it is, because something can be equally effective, but if it's not as safe, then probably should not be the preferable or the first line choice. And the 2 things, or the 2 aspects that we commonly seem to neglect, is cost and patient preference. Patient preference obviously is huge, and we just heard from Dr. Patel how some patients have certain preferences, come already with certain predetermined views on what type of treatment they should have, and it's our job as their treating physicians to ensure that at least their preferences or their decision is based on proper information. And last but not least, it's the cost component. And I think that us being doctors, we many times discuss why should we be taking cost into account. And at the end of the day, what type of cost are we talking about? Because as we know, it is the cost that the couple pays, and this is what the direct out-of-pocket money that we will see them paying, and that's in many cases the reason why some couples have very limited access to IVF, which is obviously a big issue for many societies in many countries. So what money goes out of the pocket of a couple actually many times determines on whether that couple would have IVF or not. The health insurer, who's also there to, and it could be public funding or it could be private funding, and some people say that why should we even care about this? But from either a wider perspective, and this is quite nicely elaborated by Dr. Van Mulder, who pays is equally important to what type of payment they make. Why? Because at the end of the day, either this is paid by public funding or by private insurances, it's still in a way our money. It's it's the system's money. And finally, it's the taxpayer. I might never have to have IVF, but if the resources, if part of my taxes is being allocated to IVF, I need to be aware of what's happening, and the government and the state and whoever is managing those funds needs to ensure that they're spending the money in the most wise way in order to in a way limit expenditure and maximize benefit. So within the next 10 minutes I will give you a couple of examples of how we can combine, or what type of cost effectiveness analysis we have regarding gonadotropins. And there are 2 major things that I would like us to focus on. Firstly, the fact that all these cost effectiveness analyses are based on specific clinical data and specific cost data. And where you draw your clinical data and your cost data from actually can make all the difference in terms of what type of results you'll see. And I say that because I know that very easily on top of what I present, someone might come and say, but there is that cost effectiveness analysis that shows that treatment A is better to treatment or more cost effective to treatment B, and that's not what you've told us. Always remember that it depends on the modeling, it depends on the cost data you're using, it depends on the clinical data, and sometimes it depends on how thorough or how comprehensive your modeling might be. We already heard from Dr. Van Mulder that there are many cost effectiveness analyses which look at just a portion of the cycle without taking into account, for example, safety, or HSS, or other things. So we should be always have these things in mind. So we'll be focusing in two examples in a comparison between recombinant FSH alpha, the originator, versus highly purified HMG. And of course, we'll talk about folitropin alpha originator versus biosimilars. So starting with the first question, this is a cost-effectiveness analysis that was recently published by Klaus Bühler, again as a follow-up to a study they also performed on the same topic. And it is based in real-world evidence coming from Germany using the RecDate registry. And this cost-effectiveness analysis was based on a decision tree model which was developed to include up to 3 complete ART cycles. And by complete ART cycles, we mean at least 1 fresh plus up to 3 frozen embryo transfers following a stimulation cycle, which it was assumed to be a reasonable scenario. It included pregnancy and live birth rates for 1, 2, and as I said, up to 3 ART cycles. And for every stage of the treatment, depending on when patient and whether patient had achieved a successful outcome or not, then it would be determined how their journey would continue. You can see a description here, and obviously you can read the full paper for more details. So each of the model states, which was represented by those boxes, is obviously associated with a separate cost, and there's a proportion of patients that moves between the different states depending on whether they achieved a live birth when then they conclude their journey, or whether they achieved a clinical pregnancy, they might have suffered a miscarriage or had a termination. So all these things have been factored into this model. Why? Because these are studies that are supposed to try and model in the best way possible what would happen in a real-world setting. So the total sum of all the pathways in terms of cost was used to generate the overall cost for an intervention, and in this case for folitropin alpha originator versus highly purified HMG. And the model outputs included obviously the live birth rate, the total costs associated with live births, the cost per live birth, and of course, as we discussed, a very important metric for any cost-effective analysis, which is the ICER. So the clinical data came from real-world data that were a bit older, from 2007 to 2012 by the RecDate database, and it included all women undergoing their first ART cycle during that specific study period, where the ovarian stimulation was performed with either of the 2 gonadotropins compared in this study. We included all data until delivery, including treatment discontinuation or switch to a different treatment. The occurrence of ovarian stimulation syndrome was assumed to have been captured by RecDate and therefore was not considered separately, and the probability of moving to the next model state was also based on the data of miscarriage rate, live birth rate that was provided by RecDate. The costs that we included of course all the ART costs, all the drug acquisition costs, and that was included regardless of whether it was paid by the patient, the insurance, or the state. The overall cost by ART was obtained from publicly available German sources, and of course there were some assumptions that to be made because not all data is captured in RecDate, and those assumptions were, for example, relevant to whether ICSI or IVF had been used, and in order to incorporate these, they also went to weighted averages available from German data, and also to whether these individuals had been delivered via cesarean section or vaginal birth, since the data, the cost of pregnancy monitoring and birth costs were also incorporated, but they were not included in the RecDate registry. So these are some of the treatment costs included in the model, and you can see they're all in euros. And you can see, for example, for ovarian stimulation, the OPU and insemination, it was about 700 euros. For embryo transfer, including storage, it was about 1,300 euros. And you can see that for the live birth, and that's important to outline, that was a significant cost. Probably the bigger cost was when a woman was actually reaching delivery. Live birth and all the monitoring up to live birth was included there. And it seems to be the most significant cost. So this is the total cumulative costs, as you can see, after up to 3 cycles, including a cost breakdown. And you can see on the left we have folitropin alpha originator, on the right we have HMG highly purified. You can see that they're fairly similar in a way. We have about 5,900 euros on the folitropin alpha, and 5,900 euros and 6 euros extra on highly purified HMG. Here in the circle, a very important thing is you can see out of those two treatment groups that started their journey that we ended up with 319 live births per 1,000 individuals and versus 286. And that again was based on the RECTATE data, which suggested that folitropin alpha was more efficacious. So there were slightly higher treatment costs related to birth when it came to folitropin alpha, but probably that was because we had far more births in that group. And the medication costs you can see here were lower for recombinant alpha because there was overall a lower dose used based again on the RECTATE data from 2007 to 2012. So what about the cumulative costs without ongoing pregnancies and deliveries? So if we exclude the management of a pregnancy, what's the cumulative cost? And you can see here that in terms of total costs after the first complete ART cycle, we have slightly less money spent in the folitropin alpha originator product, and that difference also persists up to 3 complete cycles. And now I think this is the most important slide of this topic, of this presentation, is what about the incremental cost-effectiveness ratio? So it was very easily seen by calculating the incremental cost-effectiveness ratio that even after just the first complete ART cycle, the originator folitropin alpha was cost-effective compared to highly purified HMG. And despite the fact that HMG might actually, per international unit, might cost less, because it was associated with, folitropin alpha was associated with a lower consumption and led to more pregnancies, it actually was cost effective at the very low level of 2,430 euros. When you had 2 complete AR cycles accounted, then cumulatively it was even more cost effective, and when you accounted up to 3 complete ART cycles, then the ICER was below 0, meaning that it was dominant, that it was both cheaper and also more efficacious, meaning that when you take into account the cumulative cost of 3 ART cycles and the cumulative effectiveness, folitropin alpha was the dominant method and therefore the one to go by. The authors did what we call a probabilistic sensitivity analysis by varying the assumptions and the cost input, most importantly the efficacy data, and they very easily saw that at a very low willingness to pay threshold, less than 20%, less than 20,000, less than 10,000, we were already approaching a near 90% acceptability rate. So even after the first cycle, there was a very high probability, more than 80%, that folitropin alpha originator would be cost effective at a threshold which was much lower than 10,000, close to 6,000 in this study. And I think this was very, very significant. And obviously, as you could expect, this probability increased when we included 2 or 3 cumulative complete ART cycles. So moving on to the second topic, the biosimilars, that we heard so many things, and it was actually discussed, and that was an excellent introduction for my talk, whether there is any cost effectiveness about biosimilars, because we all have introduced biosimilars in our practice because apparently they're equally as efficacious and cheaper. And that's what Dr. Patel with her presentation challenged. So we know that biosimilars are not identical molecules, and therefore they can actually potentially lead to different results. So there has been one significant review of all the health economic analysis in biosimilars of folitropin alpha versus the originator, which looked at everything that's been published so far. And here you can see where the biosimilars were available up to this point. This is a study by Goldstein, and you can see when they were introduced and what is happening in terms of their use. So the authors of this study took some cost-effectiveness analysis comparing biosimilars of folotropin alpha with the originator product. And actually, this, as you can see, have been performed in different settings in Italy, in Spain, Germany, France, Portugal, and they looked at all the studies. And they looked also at the ICER of folotropin alpha originator versus the biosimilars. And you can see how they've modeled it here. And in almost all cases, folotropin alpha was considered, if you took a willingness to pay scenario of like, so let's say 10,000 euros, was considered cost-effective across all studies published up to that point. And this is the cost difference per live birth between biosimilars and the originator of folotropin alpha. And with the exception of France and Michael Greenberg, it was actually cheaper to get a live birth with the biosimilars compared to the folotropin alpha. In all other scenarios, folotropin alpha was, it was actually cheaper to get. You had, a benefit, a monetary benefit in getting live births with the folotropin alpha originator versus the biosimilars. So we tried then to follow that publication and now perform a cost-effectiveness analysis, but this time using data that came from a meta-analysis we performed based on randomized control trials, because we said many times that real-world evidence is good, but what's actually great is when real-world evidence corroborate properly designed RCTs. So we wanted to perform that same experiment. So we used the Spanish setting, and we obtained clinical data from all the randomized control trials that have been performed to essentially market all the biosimilars that were available at that point in time. So the aim of our study was to compare the economic implications of variant stimulation between those two products, and to also evaluate the cost per live birth and the cost effectiveness. And we used the clinical outcomes by the recently published meta-analysis and costing outcomes from the Spanish setting. So the main outcome, of course, was cost per live birth, and other outcomes were the total cost, the live birth cost, and obviously the incremental cost effectiveness ratio. We performed multiple sensitivity analysis because we wanted to see whether our conclusions would still hold when we vary our different assumptions. And the clinical input, as I said, came from Spain, and it came from the meta-analysis, and here you can see the results of that meta-analysis in terms of ongoing pregnancy, live birth, and severe OHSS, which we also took into account. The cost data came from Spain, and we included various regional sources, including 2 key opinion leaders, and we also included all this cost data regarding different outcomes of the model. So I won't go into very much detail. I'll just tell you that the cost per live birth were lower with the originator folotropin alpha in our study than with alpha biosimilars, and that was 18,000 approximately in the originator group versus 220,000 in the biosimilar group. The total cost of treatment in the 2 cohorts was higher, but that was predominantly due to the fact that we had a higher number of pregnancies and live births in the originator. When we calculated the incremental cost-effectiveness ratio, you can see that we found that assuming a willingness to pay threshold of about 10,000 euros, which is actually quite low, and most people would argue that 20,000 euros is relevant for Europe, using the originator folotropin alpha was more cost-effective compared to using the biosimilars. The average cost per live birth is also shown here, where you can see it was lower in the originator product. And here we have the total cost breakdown, where you can again see that the main difference in costs comes from the pregnancy and the birth-related costs when you're assessing the total cost. So despite the fact that many people would think that it's the biosimilars that are, or it's the originator that's more expensive, and that is the main driver of the total costs, in multiple analyses we did, we saw that it's only a very small fraction ranging from about 6% of the costs up to 16% of the costs, depending on like up to which point you actually count where the drug acquisition costs are important. Therefore, probably contrary to most and the patient's belief, the cost of having a baby is the impact of what type of gonadotropins you choose is very limited. And we also did the cost effectiveness acceptability curves, and assuming a willingness to pay threshold of about 20,000, we very quickly saw that the originator product of folitropin alpha had almost 100% probability of being cost effective. So to conclude, these were just two examples of how health economic evaluations can inform our decision-making process in any setting on which gonadotropin to use. Health economic evaluation obviously represents an integral part of any health technology assessment, and recently we had a number of cost-effectiveness analysis published looking into the topic of gonadotropin selection, including data both from comparative real-world evidence studies and meta-analysis. And using those data, recent cost-effectiveness analysis from Germany suggests that using folitropin alpha originator is cost-effective compared to using highly purified HMG. And similarly, using data from published meta-analysis of RCTs suggests that despite the fact that potentially being more expensive, the originator folitropin alpha is more cost-effective compared to the biosimilars of folitropin alpha. So these studies obviously can provide some insight on the cost implication of available treatments. However, as with all studies based on real-world evidence, we need to be cautious about how we interpret them and how we extrapolate the results. And this is particularly true for cost-effectiveness analysis studies, where, as we said, the result you end up with is essentially tied with the assumptions you make and with a setting that this cost-effectiveness analysis has been developed for. So it doesn't mean that this data directly translate, for example, to India, but it clearly shows, and that would be the main message of today's talk, that if something is cheaper, does not necessarily mean that it's the best and it's most cost-effective in the long term. And that's why these cost-effectiveness analysis are urgently needed in every setting in order to inform patients and physicians. Thank you.